Good afternoon, and thank you for joining today's mastermind session, where we will be discussing in our part one implicit bias and patient outcomes. Today, we have joining us Dr. Sally Carlisle, who will walk us through what it means to have implicit bias, take us through what leaderships can do in order to identify driven interventions that address implicit bias and the impact it has on patient outcomes, how you as an individual can recognize your implicit biases, and what that means to the delivery of care and how we interact in today's society. Thank you for joining us today for this also important conversation and discussion, Dr. Carlisle.
Hi, my name is Dr. Sally Carlisle, and I'm going to be presenting from the Center for Faculty Excellence at Chamberlain University. Today, we're talking about implicit bias and the impact that has on patient outcomes. The outcome for today is that you will be able to identify two leadership-driven interventions that address the impact of implicit bias on patient outcomes. While that is our end goal, we'll also take some time to define implicit bias, examine personal implicit biases, as well as some strategies that you can implement as leaders. Before we get started, I would like to share a personal story that illustrates the impact that biases can have on patient outcomes. So I want to share with you Tyrone's story. Tyrone was born in the late 70s to a teenage mother and father. At around 9 months old, he was diagnosed with sickle cell disease after his mother brought him to the doctor for inconsolable crying. It's important to note that his maternal grandmother died of sickle cell-related complications in her 30s. Tyrone spent his childhood in and out of the hospital. He traveled to his doctor's appointments 60 miles away on the Oats bus because his parents were working. He often spent his hospital stays alone as his family was working and caring for his younger siblings. As a child, Tyrone enjoyed the care he received from the pediatrician and the nurses in the children's hospital. But once he became an adult, things began to change. As treatment regimens evolved, he was prescribed new medications, but never received education on how to take them or their purpose. He also noticed that the adult physicians and nurses were not nearly as nice or kind to him as those in the pediatric hospital had been. They often didn't believe the severity of his pain rating. In fact, his new doctor would only prescribe him Tylenol number 3 because he could not believe he needed that much pain medication. And this was a hematology oncology specialist, someone who knows a lot about, or should know a lot about, sickle cell in patients and the way that their pain presents. And he was even accused at times of being a drug seeker or selling his medications. Tyrone began taking the Tylenol number 3 far more than prescribed in order to manage his pain. And as time passed, his hospital visits became more and more frequent. His daughter spent much of their first 2 years accompanying him to the emergency room or visiting him in the hospital. Eventually, after years of deteriorating care, Tyrone transferred to a physician group who were more vested in his care and success. But unfortunately, it was too late, and Tyrone died at the age of 25 of sepsis, complications of liver failure, likely related to the prolonged use of Tylenol. I share this story because Tyrone was my partner and is the father of my oldest daughter. His story has inspired my purpose as a nurse, educator, and scholar. And as my career and studies have grown, I have come to understand that implicit bias likely played a role in his outcome. If we go back and look even from the beginning with his missed diagnosis, the fact that his grandmother died of the disease, that his mother had to take him multiple times to appointments, he likely experienced bias because his parents were not able to be there at his bedside when he was a child, and they had missed the opportunity for appropriate education and interventions and the ability to build trust with the care providers. So I hope that you consider this story and keep it in mind as we progress through this presentation. The next thing, I think the most important thing to talk about is obviously the definition of implicit bias. Implicit bias is different than explicit or outward forms of bias like racial slurs or, offensive flags or postings, things like that. Implicit bias is defined as attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases produce behaviors that may not align with our stated or conscious beliefs. In fact, when confronted with the biases, the offender will often say things like, "I'm not prejudiced," or "I don't see color." Consequently, implicit bias research tells us that human behavior is likely not under conscious control, and that makes it very difficult to identify, to manage, and to accept when we're called out for our implicit biases. So here are some examples of implicit bias, and probably the better way to say these are the behaviors that manifest as a result of implicit bias. As you can see, the severity of the behaviors can vary based upon circumstances as well as downward implications. So some examples, and these are just a small few. Assuming overweight individuals are lazy and or lack understanding of nutrition. The research is actually the most research that's being done on implicit bias is on weight bias, and then the implicit bias related to race and patient outcomes usually. But this weight bias is, just like anything else, it can impact a patient's willingness to trust and continue care with a provider if they feel like the provider or the nurse is judging them. Clutching your purse when you're in the elevator with a Black man, that is a manifestation of implicit bias. I actually had an experience a couple of years ago where I was visiting a friend in a downtown apartment building, and it was one of those where you either have to buzz in or swipe your fob, and I was waiting, and a young man was coming up quick behind me, a young Black man, and all of, my hair raised on my arms. I became tense, and he was just running up to swipe his fob to let me into the building. And as a mother of a Black male child, that really, produced a lot of shame for me, and it was something that I really, had to reflect upon. Another example, interesting, is expecting women in the office to clean the break room or wash dishes after activities. And I think that's something that manifests both for men and women. I mean, if I think back to when I was in the office, we would have a party, and it just seemed like many times the women, no matter their rank or role in the department, would stay and clean up, and many of the men would disappear. And it was something that nobody even really questioned. It was just this implicit, sort of ingrained behavior that everyone engaged in. Another unfortunate example, and this goes along with Tyrone's story, is failure to prescribe adequate pain management to patients of color. So I'd ask you to reflect upon a time that you've exhibited any of these or similar behaviors. What made you act that way? So what do you think it was in your social experience, your upbringing, your training? What is it that made you act that way? And then the next step is, how could that behavior have impacted the recipient? How could that have impacted an outcome, whether it be a patient, a friend, a coworker? How did that behavior impact that relationship? Now that we have some examples of implicit bias, what do we do about it? So the first step is to take an implicit bias assessment. Implicit bias can be interpreted as an abstract concept. And so the first step in mitigating bias is to take an assessment and identify your own implicit biases. So Project Implicit at Harvard has been around since the 90s. And it's offered this implicit association test. It's very unique. It's not what you think it is. The test has established reliability and validity, offering an array of assessments based on gender, sexuality, race, skin color, disability. There's several assessments that you can take to determine your underlying biases. The results of your assessment will likely surprise you and may even elicit some feelings of shame. So I've taken several of these, but I actually took an implicit association test about a month ago in preparing a talk similar to this for my organization. And I thought, let me get in there and take this test, and so that I can talk about it. And, you know, it's front of mind. The one I chose was race and weapons. And so the first thing, when you take these tests, it will ask you what you think your outcome is going to be. And so when I think of race and weapons, I think of growing up in rural Midwest with my grandfather in his old Ford truck with a shotgun hanging in the back window. And so I said, I know I am going to associate guns and old white men. So I finished the test and I came back with a moderate association, implicit association between Black men and weapons, which again was really shameful to me as a mother. And, you know, I realized at that point that I really have to take some steps to mitigate that, because that's a dangerous implicit association to have when we think about calling the police and different things that are going on in our society. So I'll talk to you all about some ways to mitigate that throughout the presentation. The essential step, though, when you get your results that you're likely not going to expect, is that you reflect on those results and be ready to change your behavior when confronted with those biases. So when you see them showing up, you have to be ready to change your behavior. Okay. So Project Implicit findings. The researchers at Harvard and a lot of other people have done significant studies on implicit bias based on the implicit association test, and they found that implicit bias is pervasive in the population. People are often unaware of their implicit biases. Implicit biases predict behavior, and people differ in the level of implicit bias. From a psychological perspective, implicit bias is more likely to manifest when our brains are overwhelmed with information and when we're forced to make quick decisions like we are every day in healthcare. Once our human responses, one of our human responses is to take shortcuts to information that our brain thinks that we already know. So we've talked about how we can be sort of socially programmed to have these implicit biases. And when we're faced with a stressful situation, instead of maybe using the training that we've had, we know we should be equitable with everyone. If we're put in a stressful situation, sometimes our brain is going to want to switch to that implicit bias and wants to take a shortcut to those images and those decisions that have sort of been ingrained in our mind. It doesn't take as long to think those through. I think that the picture here on this slide is a great illustration of implicit bias. It's really innocent, and optical illusions are a great way to illustrate bias. So the question with this one is, do you see a bunny or do you see a bird? And your answer is going to vary based upon a multitude of personal and social experiences. So I always see a bunny first. And I've decided that that's because I grew up in the Midwest, lots of bunnies. And I feel like the bird, so it's either the bunny's ears or the bird's beak, I feel like that bird looks more like a seagull or something that you would see in a tropical destination, which is not what my brain has been conditioned to think of birds as. So that's my own personal theory of why I see the bunny first. But I just think it's a great innocent illustration of how your mind can take these shortcuts. And when you stop and think about it, you say, okay, I can see the rabbit face on the right side with the ears to the left, but when you tell me, I can see the bird's beak on the left and his head on the right. So the same goes for social unconscious biases. Getting back to healthcare and patients, why do our implicit biases matter? They manifest as failure to help versus intention to hurt. So I'll say that again, failure to help versus intention to hurt. So, when we say things like, I didn't mean that, and that wasn't my intention, it's important to accept those statements, but we also have to look at the other side of that and say, but did that bias fail to help someone? And they're also difficult because they emerge in ambiguous situations where it may be easier to explain away the outcome. So in healthcare, we're under these stressful situations. We have to make quick decisions. And so rather than saying maybe our disparities in care are a function of implicit bias, it may be easier to say it's a function of staffing, or it's the patient's fault, or something like that, which those are relevant pieces, but it's important to consider both. So you can see here that implicit bias manifests in patient outcomes, interprofessional relationships, policy, training, and hiring. And all of those factors really influence one another. They also make it difficult to identify our own biases, and failure to identify implicit biases can lead to issues with patients and the workplace when they're not addressed. So let's look at the impact of implicit bias on patients. Again, we shared some more general examples earlier, and these are some more specific impacts on patients. You can see the first is maternal mortality, and I think most of you are probably familiar with the huge disparity with non-Hispanic Black women being 3 to 4 times more likely to die from pregnancy-related complications than white women when controlling for age, income, and education. So no matter that woman's, I know there was a high-profile story of a researcher at the CDC who died shortly after childbirth. Another example is treatment. So women are 3 times less likely than male counterparts to receive knee arthroplasty when clinically appropriate. So when presenting with the same symptoms that should elicit a surgical intervention, women are 3 times less likely to receive that surgical intervention. Again, non-white patients are less likely to be prescribed pain medication than their white counterparts. Lastly, diagnoses. So Black women are more likely to die after breast cancer diagnosis. The jury's out. That's a little bit of a multifaceted discussion. Is it because diagnosis is delayed? Is it because of treatment decisions once one is diagnosed? But we know that Black women are more likely to die. And all of these statistics come from the Joint Commission. In addition to these examples, implicit bias has the potential to impact patient satisfaction survey because of the correlation to provider-patient interactions. So a little bit more on those provider-patient interactions. The most really conclusive study, systematic review of the literature on implicit bias in healthcare outcomes. This study yielded 15 studies, so they're looking at other research that's been done. And they found low to moderate implicit bias in 14 of the studies. Most of the studies used the Harvard Implicit Association test to measure implicit bias. That finding is consistent with the general population according to Project Implicit. So earlier we talked about implicit bias being prevalent in our population, and that same prevalence is existing within our healthcare system. The key findings indicate that implicit bias is most noted in provider-patient interactions and overall health outcomes. So treatment decisions, treatment adherence also show up, but those provider-patient interactions. And that could be potentially why we see the impact on surveys and things like that. But when you think about treatment adherence and decisions, the trust factor that's established in those provider-patient interactions is really where all of that starts. So we know that implicit biases exist. We can't deny them. So what do we do about it as leaders? I'll start by saying that evidence regarding effective interventions to mitigate implicit bias is in its infancy. We have some evidence, but not a lot. We will discuss inclusion efforts at the micro, meso, and macro level that may be helpful. And so for the purposes of this presentation, micro is going to be defined as individual contributors. The meso level will be sort of unit department level, and the macro will be the organizational level. Macro level interventions. Really, the goal should be to institutionalize fairness in the organization. Does your organization's mission and vision reflect a commitment to diversity, inclusion, or social justice? You might consider implementing and monitoring a disparities dashboard to monitor patient disparities within the organization in time. And then you can develop interventions based upon that data that may come down to the meso micro level. Implement an equity lens when developing policies related to equity, inclusion, and social justice. This is an example of an equity lens. It provides an opportunity to assess the impact of policy on people, the organization, and process power. And I like to think of this as sort of organizational introspection. So I know this slide is a little small, but if you put implicit bias as sort of that concept that you want to evaluate in your policies, you can work through a lens such as this to help you determine where there may be areas for improvement within your organization. Meso level interventions. Staff education. The jury is out on the effectiveness of implicit bias training. We know that the standard HR slides, knowledge check is not effective. We know that. There is some evidence supporting simulation as an effective intervention to address implicit bias. That training should purposefully include manifestations of implicit bias with planned debriefing questions to examine the impact. So you would really need a subject matter expert and an expert in simulation and debriefing to design that experience. Perspective taking and messaging are also important factors in implicit bias education. Once communities served by your organization are identified, you want to allow opportunities for colleagues to take the perspective of a member of that community. And this could be vignettes, videos, reading books, movies. The goal is to walk in their shoes. An example that I have is after I got my shameful implicit association results a month ago, I really started, my son's a violinist, so I started following two young men who play the violin on social media, and I watched them religiously, and that's one thing that really is contrary to my implicit association, and I'm using that as sort of a perspective taking measure. Lastly, you want to consider if implicit bias is influencing hiring practices within your units. Is your workforce reflective of your patient population? If so, that's great. Why do you think that is? What are you doing? That may be an opportunity for you to share best practices. If not, then that's an opportunity to dig deeper, maybe use that equity lens and focus on your hiring practices and determine why that staff population is not reflective of your patient population. The micro level interventions have the most evidence to support their effectiveness. My first piece of advice would be to have everyone take that implicit association test, and helping them understand that they may get a result that they don't like or they weren't expecting. That first step is to identify bias. Practicing mindfulness. This is interesting, and it can be a little bit difficult, I know, for the clinical setting, but there's some sound evidence that practicing yoga, meditation, or guided imagery prior to an interaction where you know implicit bias could surface, so stressful time, can be effective. Participants have actually scored lower on the IAT after completing mindfulness training. The one that's probably most important and I would think implementable for other than the IAT for the clinical environment is slowing down. As we've said repeatedly, unconscious bias is more likely to manifest during stressful situations. Employees need to understand this and, when appropriate, slow down prior to making impactful decisions. We know that that can't always happen, but if there could be some sort of timeout like we have in surgery, you know, if you notice you have a disparity, maybe implementing a plan that allows the staff to sort of slow down and check their bias before they proceed through whatever that interaction is. Lastly, you know, through all of this, you know, implicit bias is obviously personal, it's an individual experience. I think the most important thing that we can all do is reflect on our own biases, reflect on where we've misstepped. If someone calls us out for that bias, we have to accept it and then start thinking about what we're going to do. How did we get ourselves in that situation? And then, of course, how will we do better next time? This reflection is so important. So that is the conclusion of my presentation for today. I thank you for allowing me to speak on this very important topic.